Dear my friends and colleagues, it looks like it's for the first time I'm presenting in English for you. However, my Ukrainian is not good enough to do it. So our first presentation today will be related to aspiration during cesarean delivery. It's a very important subject, and we'll try to find what we know today about this old paradigm. Pulmonary aspiration is a very well-known complication of general anesthesia, okay, and of course, pregnant patients are in risk factor due to delayed gastric emptying and higher incidence of difficult airway. You, of course, remember this publication by Mendelssohn, where he described aspiration chemical pneumonitis in 1946 with very high mortality in pregnant patients. As a result, neuraxial anesthesia has become the gold standard in obstetrics, significantly decreasing cesarean deliveries performed under general anesthesia. And ASA recommended a pharmacological aspiration prophylaxis as a standard practice for cesarean delivery. First of all, I'd like you to introduce you our relatively new publication where we analyzed incidence of aspiration during general anesthesia for cesarean delivery. We focused on clinically significant aspiration because very minimal changes in area of epiglottis with chemical change of pH can be clinically significant, and we talked about only patient that needed admission to ICU. This study had a retrospective character and was performed during 11 years in Soroka University Medical Center and Shaare Zedek Medical Center in Jerusalem, in Israel. These two hospitals are very big, and we have about 18,000 deliveries a year with incident point 17 to 20,000 deliveries a year with percent of cesarean section about 16. During this 11 years study period, we found almost 50,000 patients underwent cesarean delivery. Of them, 69,000 patients underwent cesarean delivery under general anesthesia. It's about 46%. And the rest of patients underwent cesarean delivery under spinal anesthesia or neuraxial anesthesia, 53%. Here I probably could explain, here in South region of Israel, we have a very special population that prefer general anesthesia over regional anesthesia. That is why we have very high percentage of cesarean deliveries under general anesthesia, okay? So it's like a Klondike for studies that require a general anesthesia for cesarean section. You can see that during this study, we evaluated charts of all the patients that were submitted to intensive care units. And of them, we found the patients who had any kind of lung injury, aspiration, desaturation, whatever that could get us focused on the aspiration. As a result, we found that only 3 patients in our study had incidence of aspiration, very, very low incidence, okay? Of them, 2 patients had aspiration under general anesthesia, and one of them was in neuraxial anesthesia with light sedation. So, as you can see, general anesthesia is not really associated with high risk of aspiration. Well, let's check the information in the literature about that. In SCORE project, analysis was performed to identify serious complications associated with obstetric anesthesia. There were no cases of aspiration among more than 5,000 cesarean deliveries performed under general anesthesia, also very low incidence of aspiration. Okay, the next study was a study where the authors examined abilities to perform general anesthesia for cesarean delivery with laryngeal mask, specifically supralaryngeal mask. And they performed 500 cesarean deliveries under general anesthesia with laryngeal mask airway, and there were no cases of pulmonary aspiration. Well, if we look at confidential injury of maternal death from France, in period from 2013 to 2015, there was only one case of aspiration and no death during this period. Between years 2019 and 21, there was also no case of death as a result of aspiration during cesarean section. Regarding specific risk factors, Warner and colleagues in a study examining 15,000 patients under general anesthesia identified higher SA physical status as associated with increased aspiration potential, but age, gender, pregnancy, obesity, and surgery were not found to be independent risk factors. So as you can see, again, pregnancy is not absolutely risk factor for aspiration as it was supposed to think. I can't not talk here about controversy existing in the literature regarding the use of cricoid pressure. Well, as you probably know, cricoid pressure was described first by Selig in 1961 and introduced into our literature as Selig maneuver to control regurgitation of gastric content and prevent aspiration until the placement of cuffed endotracheal tube is confirmed. The Selig original paper was applied to 26 patients at high risk for aspiration. None of the patients aspirated, and 3 patients' immediate reflux of gastric content into pharynx was observed. Again, just 3 cases of potential regurgitation, but not aspiration. Although considered a landmark observational study, it's only included a small amount of patient, was non-randomized, and only included anesthetic technique available in year 1961. This is the original paper, you can see it, okay? It's very short, describing this technique of cricoid pressure. Well, in Prip's review of the literature, it was demonstrated that most of the perceptions regarding the proposed benefits of cricoid pressure are not evidence-based. So no publication that could support this technique for effective preventing of aspiration during induction of general anesthesia. Why it happened? There have been many cases observed in which aspiration occurred despite the use of cricoid pressure. Radiographic and endoscopic studies have questioned the procedure's efficiency. In the absence of cricoid pressure, the esophagus was found to be lateral to the cricoid in more than 50% of the patients. Okay, so this is an anatomical abnormality that we can see in every second people in population. The application of cricoid pressure resulted in faster displacement of both the esophagus and larynx laterally in 19% of people. 90% of people we can't perform this cricoid pressure properly. Can see esophagus that supposed to be compressed between cricoid cartilage and body of vertebra is located in lateral position, and actually this maneuver doesn't work. Okay, so applying of cricoid pressure prevents proper performing of esophageal obstruction. Well, so although studies recommend that force of 10 to 20 newtons should be applied to the cricoid cartilage for the awake patient, and then 30 to 40 newtons when the patient is unconscious, most anesthesiologists do not know how much force should be used during the application of cricoid pressure. Only 1/3 of anesthesiologists applied the required force during application of cricoid pressure, and as few as 5% of nurses or surgeons apply adequate force. So this is the people that usually help us to perform induction to anesthesia, and they don't know how to apply cricoid pressure. And even more, application of cricoid pressure during rapid sequence induction is not a risk-free procedure. Cricoid pressure during rapid sequence induction may in fact increase the risk of aspiration, and cricoid pressure results in a decreased tone of lower esophageal sphincter. Even when applied correctly, cricoid pressure has been shown to worsen the laryngoscopic view. So altogether, this technique is very ineffective and not suitable in vast majority of the cases. And even more, cricoid pressure has also been shown to impede or even prevent fiber optic intubation, so it's not suitable for fiber optic intubation. During regurgitation, esophageal pressure may exceed 60 centimeters of water, which may cause esophageal rupture. So in case of regurgitation, we need to release cricoid pressure. This is a common recommendation. And in this case, we actually allow gastric contact to aspirate to get regurgitated and enter the trachea. So as you can see, actually there is no evidence for cricoid pressure. It's like anecdotal and not evidence-based. So according to this information, this practice has already been abandoned by as many as 50% of anesthesiologists, including myself, many years ago. This is the only prospective randomized controlled double-blind study that examined effect of rapid sequence induction and its efficiency. As you can see, it was performed in 10 academic centers, included 3,500 patients enrolled into the study. They were equally divided into celiac maneuver group and non-celiac maneuver group. And as a result, the authors found that about 0.6% of patients in the celiac group and 0.5% in shame group had aspiration. So absolutely equal without any profit of celiac maneuver. So conclusions that large RCT performed in patients undergoing anesthesia with rapid sequence induction failed to demonstrate the non-inferiority pump procedure, sham procedures, in preventing pulmonary aspiration. Thank you very much for your attention. See you in future.